Welcome to the deep dive. Today, we're jumping into a really important topic, especially if you're trying to get a solid grasp on genetic bleeding disorders.
That's right.
We're talking about Haemophilia B. You might also know it as Christmas disease.
Mm-hmm.
And the idea here is really to streamline things, get you the essential info without you having to wade through, tons of dense text.
Exactly. We've sort of condensed a whole set of detailed notes into the key takeaways. Our goal, really, is to give you a clear, high-yield overview, covering all the bases, what it is, how it works, management.
And hopefully some useful memory aids along the way.
Yeah, trying to make it stick.
Okay, brilliant. So let's start right at the beginning. What exactly is Haemophilia B?
Okay, so Haemophilia B, or Christmas disease, as you said, it's fundamentally a genetic bleeding disorder.
Yeah.
And the core problem is a lack of, or deficiency in, clotting factor IX.
Factor IX.
It's an X-linked congenital disorder. So, it's tied to the X chromosome, and it's something people are born with.
And you often hear about Haemophilia A as well. How does B compare?
Good question. It's definitely rarer than Haemophilia A, which involves factor VIII deficiency. And generally speaking, Haemophilia B tends to present a bit milder, though severity can vary quite a bit, as we'll see.
Okay.
And for those really into the genetics, the specific gene, the F9 gene, is located on the X chromosome at XQ27.1, Q27.2. Knowing that helps pinpoint mutations.
Gotcha. Now, the notes mention something quite unusual, the Leyden variation. Tell us about that.
Ah, yes. The Leyden variation is fascinating. Basically, you have individuals who are born with really low factor IX levels, like less than 1%. So severe symptoms.
Right, severe.
But then when they hit puberty, something remarkable happens. Their factor IX levels can actually start to increase, potentially due to testosterone kicking in.
Wow.
Yeah, sometimes they can even reach near normal levels, which is, pretty surprising. It means someone's symptoms might dramatically improve after puberty.
That could definitely complicate diagnosis if you weren't aware of it.
Absolutely. It's a key detail.
So stepping back a bit, what's the root cause, the etiology?
It all comes down to that X-linked recessive inheritance pattern. The underlying issue is a mutation in the F9 gene.
The one you mentioned earlier.
Exactly. That F9 gene holds the instructions for making factor IX. So if the gene's faulty, you don't make enough functional factor IX, or sometimes none at all. Think of clotting like a cascade, or dominoes falling. Factor IX is a critical domino.
And if it's missing or broken?
The chain reaction stalls. Clotting is impaired.
And in terms of risk factors, who's most likely to inherit this?
Well, the biggest risk factor, unsurprisingly, is family history.
Mm-hmm.
If Haemophilia B runs in the family.
That increases the risk.
Significantly.
Mm.
And because it's X-linked, it predominantly affects males who have just one X chromosome. Females with two X chromosomes, if they inherit one faulty gene, they're typically carriers. They usually don't have severe symptoms themselves, but they can pass it on.
Okay, that makes sense. So we know there's this lack of factor IX. What does that deficiency actually do in the body, the pathophysiology?
Right. The core problem is you don't have enough working factor IX protein. Factor IX is absolutely essential for that clotting cascade I mentioned.
Part of that chain reaction.
Exactly. It's a key player in forming a stable blood clot. So without enough of it, the whole process is inefficient, it's slow. The consequence is that bleeding goes on for much longer than it should after any kind of injury or surgery, or even sometimes spontaneously.
So if someone presents with these kinds of bleeding issues, Haemophilia B is on the list. But what else needs to be ruled out? The differential diagnosis.
Oh, definitely. You can't just jump to Haemophilia B. You have to consider other possibilities. Top of the list, naturally, is Haemophilia A, factor VIII deficiency. Looks similar clinically sometimes.
Right.
Then there's von Willebrand disease. That's another common inherited bleeding disorder, but it involves a different protein, von Willebrand factor, and often affects platelets too.
Okay.
You also need to think about factor IX inhibitors. This is where the body actually makes antibodies against factor IX even if it's given as treatment. That complicates things.
I can imagine.
Then simpler things, perhaps, like vitamin K deficiency. Vitamin K is needed for several clotting factors. Or liver disease, because the liver makes most of these factors.
Makes sense.
And you'd also consider platelet disorders, problems with the platelets themselves, and in certain, often more complex, acute situations, maybe even something like disseminated intravascular coagulation, or DIC.
So quite a few mimics.
Yeah, ruling those out is crucial for getting the right diagnosis and therefore the right treatment.
Let's talk numbers then. How common is this condition, epidemiology-wise?
Okay, so in the UK, we're looking at roughly one case in every 25,000 male births.
Okay.
Globally, the prevalence is estimated around 1 in 30,000 live births overall, which, as I mentioned, makes it about 5 times less common than hemophilia A.
Right. And you mentioned severity varies. How is that classified?
Yes, the classification is based directly on the measured factor IX activity level compared to normal. So severe is defined as having less than 1% factor activity,
Less than 1%.
and that counts for about half of all cases. Little mnemonic here. Think severe single-digit percentage, like less than 1.
Okay, severe single digit. Useful.
Then moderate is between 1% and 5% activity. That's about 30% of cases. So moderate, more than 1.
Got it.
And mild is factor activity between 6% and 30%. That's the remaining 20% or so. Think mild exceeds moving towards normal.
Severe, moderate, mild. Less than 1 to 5, 6, 30%. Those mnemonics are helpful.
Hope so.
And does it affect certain populations more than others?
Geographically, no. It occurs worldwide across all racial groups. Inheritance-wise, we touched on this, but for a carrier mother, there's a 50-50 chance with each pregnancy, 50% chance of an affected son, 50% chance of a carrier daughter.
Right.
An important point, sons of men with hemophilia B will not be affected and won't carry the gene because they get their Y chromosome from their father and their X from their unaffected mother.
Okay, that's key.
And there's another interesting genetic quirk sometimes. Very rarely, carrier females can have mild bleeding symptoms. This is thought to be due to something called lionization or skewed X inactivation.
Lionization, right, where one X chromosome is randomly inactivated in each cell.
Exactly. If by chance the X chromosome carrying the normal F9 gene is inactivated in a large proportion of the relevant cells, the woman might have low enough factor IX levels to experience mild symptoms.
Fascinating complexity.
It is. And one last point on epidemiology, while most cases are inherited, a proportion, maybe up to a third in some studies, arise from spontaneous new mutations in the F9 gene, meaning there's no prior family history. Some areas like Sweden apparently report higher rates of these spontaneous cases.
Okay, so moving on to what it actually looks like in a patient, what are the key clinical features we should be aware of?
Well, the classic signs revolve around bleeding, obviously. Prolonged bleeding after an injury or surgery is a big one. Easy bruising is very common, too. Then there are the spontaneous joint bleeds, hemarthrosis. That's quite characteristic, especially in more severe forms. Remember, hemoarthropathy equal joint problem. It highlights that link.
Okay, joint bleeds.
You might also see excessive bleeding from just minor cuts, things that wouldn't normally bleed much. And nosebleeds, epistaxis, can be frequent or difficult to stop.
And does this presentation differ much depending on that severity classification you gave us?
Oh, absolutely. It differs significantly. Someone with severe hemophilia B, less than 1% factor IX, they often have symptoms right from infancy. Lifelong issues. They get those spontaneous bleeds, especially into joints and muscles, frequently. And they have a higher risk of really dangerous bleeds, like intracranial hemorrhage. That mnemonic brain bleed is BAD, is a stark reminder of the risk there.
Definitely.
With moderate hemophilia B, the 1-5% group, bleeding usually follows minor trauma or surgery. Spontaneous joint bleeds can still happen, but perhaps less frequently than in severe cases. And then in mild hemophilia B, 6-30%, the person might only realize they have it after significant trauma, like a bad accident or major surgery, when they bleed much more than expected. Sometimes taking medications like NSAIDs, which affect platelets, can be enough to trigger a bleeding episode in someone with mild disease.
So it might go undiagnosed for quite a while in milder cases.
Very possibly, yes, until there's a significant challenge to their clotting system.
What about in infants, maybe before a formal diagnosis is made? Are there specific things parents or doctors might notice?
Yes, definitely. In newborns, especially if the family history wasn't known, you might see a really large hematoma, like a big bruise or swelling, just from the delivery process itself.
Okay.
Or excessive bleeding from the heel prick test, the routine newborn screening. If the baby is circumcised, prolonged bleeding afterwards is a major red flag.
Okay.
Even things like routine immunizations, getting shots, or later when they lose baby teeth if there's unusually heavy or prolonged bleeding, that should raise suspicion. Excessive bruising, just from normal toddler bumps and tumbles, could also be a sign.
What else?
Sometimes the first signs might be musculoskeletal, a child complaining of pain or stiffness in a limb, or being reluctant to use an arm or leg, which could indicate an underlying joint bleed. And of course, if there were, heaven forbid, a bleed inside the head, you'd see neurological signs, lethargy, vomiting, seizures. Less commonly, you might see blood in the urine or stool, indicating GI or urinary tract bleeding or persistent oozing from the gums or mouth.
Okay, a wide range of signs to be aware of, especially early on. So if hemophilia B is suspected, what investigations are done to confirm it?
All right, blood tests are key. You'd start with some basics. A full blood count. Hemoglobin might be low if they've had significant bleeding, but it could be normal. White cell count is usually normal, helps rule out infection. Platelet count is important. It should be normal in hemophilia B, so if it's low, you think about other causes.
Makes sense.
Then the crucial clotting tests. Prothrombin time, or PT, measures the extrinsic pathway that's typically normal in hemophilia B.
Normal PK. Okay.
But the activated partial thromboplastin time, APTT, which assesses the intrinsic pathway. That's usually prolonged, especially in moderate and severe cases. It might be borderline or even normal in very mild cases sometimes.
So the APTT is the key one there.
It often is the first abnormal lab finding, yes. And here's that mnemonic again, just to really drill it in. APTT prolonged in platelet problems, NO. It's prolonged in factor problems like hemophilia B, helps avoid that common confusion.
But that is a good one. Okay, so a prolonged APTT points towards it. What next?
The definitive test is the factor IX assay. This directly measures the percentage activity of factor IX in the blood. This confirms the diagnosis and tells you the severity. Is it severe, moderate, or mild?
The crucial number.
Exactly. Then, especially after diagnosis and starting treatment, you need to periodically check for inhibitor levels. That's testing for those antibodies against factor IX that can develop and make treatment less effective.
Right, the inhibitors.
Some specialist centers might also use thromboelastography, or TEG, which gives a more dynamic sort of global picture of clot formation breakdown.
Yeah.
And once hemophilia B is confirmed, genetic testing, the factor IX mutation analysis, can identify the specific defect in the F9 gene. This can be useful for genetic counseling and predicting potential inhibitor risk in some cases.
And imaging.
Imaging comes in mainly if you suspect a bleed in the specific location. So CT scans of the head if there's any concern about intracranial bleeding, and X-rays, MRI, or sometimes ultrasound Doppler of joints if you need to assess for acute hemoarthrosis or chronic joint damage.
Okay. And you mentioned early diagnosis for newborns.
Yes, if the mother is a known carrier, you can test the cord blood right at birth for factor IX levels to get an immediate diagnosis.
Very thorough workup. So once the diagnosis is confirmed, what's the management strategy?
Management really revolves around replacing that missing factor IX. The mainstay is intravenous infusion of factor IX concentrates.
Okay, AV factor dix.
And there are broadly two approaches to using it. One is prophylactic treatment.
Prophylactic.
Yeah, meaning regular scheduled infusions, maybe a couple of times a week, to prevent bleeds from happening in the first place. This is generally the standard of care, especially for severe hemophilia B.
To stop the bleeds before they start.
Exactly. Yeah. The other approach is on-demand treatment. That's where you only give the factor IX infusion when a bleed occurs to treat it. This might be used for milder cases or if prophylaxis isn't feasible for some reason. The choice really depends on the severity and the individual's bleeding pattern and lifestyle.
What about emergencies? A major bleed happening right now.
Acute major bleeding is a medical emergency. Absolutely. Priority one is rapid diagnosis. Figure out where the bleed is, often using CT scans, especially if it's internal or suspected in the head. And then immediate treatment.
Get the factor in fast.
As fast as possible. The goal is to give recombinant factor IX, that's the genetically engineered version, preferred for safety, aiming to get the patient's factor IX level up to 100% activity, ideally, or close to it.
And if recombinant isn't available right away.
In a true emergency, if recombinant isn't on hand, you could use other options like monoclonal antibody-purified factor IX concentrates or older products like plasma or cryoprecipitate, but those carry higher risks, especially of infection, and are less concentrated. Recombinant is definitely first choice.
Okay. The notes also mentioned adjunctive therapies like desmopressin and aminocaproic acid.
Right. Now, it's important to be clear here. Desmopressin, DDAVP, primarily works by boosting factor VIII and von Willebrand factor levels. So it's really useful in mild hemophilia A and some types of von Willebrand disease, but it doesn't directly increase factor IX.
Right.
So generally not used for hemophilia B.
Okay. Good clarification.
Aminocaproic acid, or a similar drug called tranexamic acid, is useful though. These are antifibrinolytics. They don't help form the clot, but they help stabilize the clot once it's formed, preventing it from breaking down too early. They're particularly good for mucosal bleeding, like in the mouth or nose, or before dental work.
Okay, so antifibrinolytics can help stabilize things.
Yes. And after a severe bleed, you'd typically need to maintain those higher factor IX levels with further infusions for maybe 7 to 10 days to ensure healing.
Makes sense. What about ongoing prescribing considerations?
Well, as mentioned, for kids with severe hemophilia B, regular prophylactic factor IX is strongly recommended, often starting quite young and continuing at least until they finish growing, to protect their joints from damage caused by repeated bleeds.
Prevent that arthropathy.
Precisely. The exact dose and frequency of infusions needs to be tailored to each person, their weight, their activity level, how quickly they metabolize the factor. For minor bleeds, sometimes just local measures like pressure and elevation are enough, or a single dose of factor IX might be needed.
And surgery.
Any elective surgery requires careful planning with the Hemophilia Treatment Center. You need to boost the factor IX levels significantly, usually aiming for 50–100% activity around the time of the procedure and maintaining elevated levels during recovery.
And genetic screening.
Crucial. Offering genetic screening and counseling to potential carriers in the family is a really important part of comprehensive care.
Beyond the medications, what about lifestyle advice? Non-prescribing advice.
Yeah, that's vital too. Patients, especially those with moderate or severe disease, need to avoid activities with a high risk of injury, particularly head injuries or joint trauma. So, high-contact sports like rugby or boxing are generally out.
Okay.
But importantly, this doesn't mean wrapping them in cotton wool. Regular physical activity is actually encouraged. Safe activities like swimming, cycling, walking are great for maintaining muscle strength, joint health, and overall fitness. It's about finding the right balance.
Finding safe ways to stay active. Good point. So just to recap the general management principles.
Okay, key points. Recombinant factor IX is first line for acute bleeds, safer and effective. In an emergency bleed, don't delay treatment, waiting for lab results. Treat based on clinical suspicion.
Get the factor.
Yes. If recombinant is truly unavailable, FFP or cryo are fallback options, but know the risks. Pain management is important for bleeds. Antifibrinolytics like tranexamic acid are useful, especially for mucosal bleeding and dental procedures.
Right.
Surgery needs that multidisciplinary team approach. Prophylaxis is key for preventing joint damage in severe cases. Recombinant products have hugely reduced the risk of viral transmission that plagued older treatments.
A massive step forward.
Huge. And regular prophylaxis might even lower the risk of developing those tricky inhibitors. And finally, those lifestyle adjustments to minimize trauma risk are always part of the conversation.
That's a great summary. With all these improvements in care, what does the prognosis look like now for someone with hemophilia B?
The prognosis has changed dramatically, honestly. With proper management, especially access to factor replacement therapy, life expectancy and quality of life are vastly improved compared to, say, 50 years ago. Many can live near normal lifespans.
That's fantastic news.
It really is. Modern therapies and better screening of blood products preventing infections like HIV and hepatitis C have been game changers. However, as the population with hemophilia ages, we are seeing new challenges emerge.
Like what?
Well, managing typical age-related conditions, diabetes, high blood pressure, heart disease, even cancer alongside the hemophilia. There can be interactions between treatments or specific risks. Chronic viral infections, particularly hepatitis C acquired from older treatments, can lead to long-term liver problems. Kidney issues can also arise.
So, new complexities in an aging population.
Exactly. And reproductive choices remain complex for affected families, requiring good genetic counseling. Those genetic tests are invaluable now for identifying carriers and offering prenatal diagnosis if desired. And looking ahead, gene therapy is the big hope.
Gene therapy.
Yes, clinical trials are showing real promise. The idea is to provide the body with a working copy of the F9 gene, potentially allowing it to produce its own factor IX, maybe even offering a long-term cure, or significantly reducing the need for infusions. Still early days in terms of widespread use, but very exciting.
Wow, that could be transformative. Despite all the progress, though, what complications can still occur?
Unfortunately, yes, complications are still a reality. The biggest long-term one is probably hemophilic arthropathy, the joint damage from repeated bleeds. Hemorrharopathy, a joint problem. Even with prophylaxis, some joint damage can accumulate over time, leading to pain, stiffness, and reduced mobility.
Okay.
Intracranial bleeding, though less common with prompt treatment, remains the most feared acute complication. Brain bleed is bad too. Chronic pain, often related to joint damage, can significantly impact quality of life.
And the inhibitor.
Inhibitor development is still a major challenge for a subset of patients, maybe more common in those with certain genetic mutations. It makes standard factor replacement ineffective and requires specialized, often more complex and expensive treatments.
Right, a big hurdle.
And as mentioned, Historically, infections like HIV and hepatitis B and C from contaminated plasma products were devastating. That risk is virtually eliminated with recombinant factors. But the long-term consequences for those infected years ago persist, including increased risk of liver disease, cirrhosis, and liver cancer.
A difficult legacy.
Indeed. Prognosis is definitely worse for those with co-infections. Interestingly, there's some data suggesting that people with hemophilia who don't have HIV might actually have a lower rate of death from certain cancers compared to the general population. The reasons aren't fully clear, but it's an interesting observation.
That is curious.
But overall, the key to minimizing complications is comprehensive care at a specialized treatment center, early detection of any issues, and consistent adherence to the treatment plan.
This has been incredibly thorough. So just to wrap up the key takeaways on hemophilia B, it's that X-linked genetic disorder, deficiency of factor IX, causing bleeding issues that range from mild to severe.
Exactly. Presentation varies, but include things like easy bruising, prolonged bleeding, and those characteristic joint bleeds, especially in severe cases.
Diagnosis relies on clotting tests, specifically the APTT, and crucially measuring the factor IX activity level.
And management is centered on factor IX replacement, ideally with prophylactic recombinant factor IX for severe cases, along with lifestyle advice and managing any complications that arise.
And importantly, the outlook is much, much brighter now thanks to these treatments, with gene therapy on the horizon offering even more hope.
Absolutely. It really showcases how far medical science has come in tackling these inherited conditions. If you, the listener, want to consolidate this knowledge or explore further, definitely check out pastthensSDA.com and freemishra.com. Great resources there.
Fantastic. It really makes you appreciate the progress in understanding and treating genetic disorders. Thanks so much for walking us through all of that today.
My pleasure.
We'll catch you on the next Deep Dive.